It's a pleasure to present the next speaker. He was my fellowship director at UT Houston in Neurointensive Care, Professor Kiwon Lee. He's an internationally renowned academic neurointensivist and vascular neurologist, a graduate of Columbia University. Right now he is the professor of neurology at Rutgers, the State University of New Jersey, Robert Wood Johnson Medical School. He's also the chief of neurology at Robert Wood Johnson University Hospital. He also serves as the director of Robert Wood Johnson Comprehensive Stroke Center, division chief of stroke and critical care. He authored many peer-reviewed articles, and also he is the editor of, by the way, this is not an advertisement because this is really a good book, the Neuro ICU book. It's a very good evidence-based approach and provides the readers with a robust, wide-ranging scope that goes beyond the classic neurology. Thank you, Dr. Lee, for being with us today. And he's going to talk to us about the therapeutic options for ICH, including MAP, ICP, CPP, and evacuation. Dr. Lee, the Zoom is all yours.
Thank you, Tarek. It's so nice to see you, even though it's through a virtual platform. I want to first thank Dr. Suhail Arukan, and of course, Dr. Al-Maghrabi, and the secretary and organizers of this wonderful meeting. As you all know, the pandemic has changed the way we communicate and exchange educational forums, but hopefully we will be able to do this in person in the near future. So I will. I just enjoyed listening to Dr. Edward Jacques' a beautiful presentation. Really fundamental principles. All of the fundamental principles have been discussed during his talk. So I will focus on some of those top topics. For this talk, I will be discussing a spontaneous, non-traumatic, no underlying vascular abnormalities. So we're not going to be talking about aneurysmal bleed or AVM ruptures, but spontaneous ICH. As you all know, these are most commonly driven by underlying hypertension, with the epiteminal ICH being the most common kind. As you can see in these pictures, you can see all types of different ICH, well, spontaneous ICH, and they come in different sizes, shapes, as well as whether it's been extravasation has occurred into the intraventricular spaces or not. You've heard an excellent talk about what you should do in the first hour or so. Well, it's ABC and EVD, and EVD, external ventricular drain, obviously is for those with intraventricular extension. If you don't have hydro, if you don't have IVH, you may not need EVD. But even then, if patient is comatose and you need to get more functional tissue data, you might want to place a bolt to assess the intracranial pressure. The usual emergency treatment for the early days of the ICH is, as you heard, the systolic blood pressure. Well, the 140, 160, as you heard, it is safe to lower it. In the beginning, many decades ago, people were worried about reducing the perfusion pressure. Oh, if I drop the blood pressure, I don't want to create ischemic injury. And the evidence is such that you can probably lower it. And you've heard that. Secondly, you want to reverse any underlying coagulopathy. Yours also heard about this. If you have an underlying coagulopathy, whether it's due to a genetic, hereditary, or due to medication that you normally take, such as antiplatelets, anticoagulations, coagulopathy must be reversed. I agree with the previous speaker that you don't want to give routine, you don't want to use routine use of platelets. There's no evidence for it. However, if you're going to drill a hole on somebody's head, if you're going to put an EVD, if you're going to cut open and evacuate, or minimally invasive surgical evacuation, which I'll talk about later, you don't want to do that while platelets are not sticky. So you can give some units of platelets for certain therapy, certain antiplatelet agents. Platelet transfusion is really the only effective way. For aspirin in vitro, 81 to 90% reversal has been seen if you inject 0.3 mic per kg per each dose of a desmopressin DDAVP. It's thought to increase factor VIII as well as von Willebrand factor. And in vitro, again, has been shown to be effective in reversing the effect of aspirin. Something you might want to do if you're going to do something like this. It's easy for medical people, including myself, just to say, well, don't reverse, there's no evidence. But if you are the one placing the hole yourself, trust me, you're going to have anxiety without reversing it. So it's probably a safe thing to do if you're going to surgically intervene to reverse even aspirin. And certainly underlying anticoagulation. Not going to talk about the new reversal agent because that's a talk that deserves its own 1 hour, which I don't have, and I would love to talk about it later if you invite me again. Some of the reversal is a hot topic. For example, andexanet alpha for some of the novel factor 10 antagonists that we currently use. Those would be for another time. If you have an ICP monitor, say a bolt, or for thalamic bleed with a large IVH, for which you have placed an EVD after reversing aspirin, Plavix, and Eliquis, or rivaroxaban, then you're going to get a waveform as well as a number. A number would be the pressure measured in millimeters of mercury or water. And then you're going to, just like an A line, when you place an arterial line, you get a blood pressure waveform. Well, guess what? You're going to get an ICP waveform. Here are 3 notch, P1, P2, P3, rather a normal one where this in the middle, P1 being higher than P2. But if you have a consistently higher P2 at the height of P1 or even higher than P1, then you're talking about someone's brain that is not compliant, and that has lots of connotations and implications. Let's imagine that you have a pretty large ICH in the thalamus, and you have bad IVH, intraventricular hemorrhage. After ABC and you've placed an EVD, and the EVD, when you close it, the measurement is indicating a 35 millimeters of mercury. Guess what? The nurse, the ICU nurse will call you. And they'll say, doctor, ICP is 35. And I learned the normal is 0 to 20. 35 is much higher. I don't want the brain to melt. What do? A, well, let's call the pharmacy and get the good old mannitol, osmotic diuretic. It'll reduce the ICP. B, well, I'm going to use a little bit more modern therapy and use a high concentration, low volume, 30 ml, a 23.4% hypertonic saline, so-called salt bomb, IV push over 10 minutes, has been shown to dry the brain and reduce the ICP rather rapidly. And if you think about the comparison between 10-minute IV push versus 50 or 100 gram of IV mannitol, those of you who have hung IV mannitol, you know it takes a while. It takes 20, 30 minutes to slowly infuse into the patient's body. That takes time. C, well, instead of a bolusing, I'm going to start a lower concentration, but a continuous drip of a hypertonic saline. at the infusion rate of 100 cc's per hour. And I'm going to daily target a serum sodium level of 150 MEQ per deciliter. This is gentler, and I want to have a daily target. D, well, I'm going to grab the respiratory rate button and I'm going to hyperventilate the patient. And I'm going to measure the CO2 by ABG and make sure CO2 is dropped to 30 millimeters of mercury. I know that hyperventilation works faster than any of these A, B, or C. And I am running out of time. It's an emergency. ICP is 35, and I want to do something that works immediately. Or E, well, all of these make sense, but I need more data. I know somebody raised a hand. I would, if you can just type it in the chat, I'll answer at the end in order to make the flow more smooth, flow of the talk. In my mind, all those answers are valid. But in my mind, the answer at this moment in time is I need more data. The data and the questions you should immediately have in your mind is that, is the EVD working? Don't believe the number until you confirm the fidelity of the device that you have put in. Is the ICP waveform reliable? For those of you who have done intensive care medicine and placed an arterial line in somebody's radial artery, you know that not all A lines readings are accurate. It depends on the waveform. So first and foremost, before you grab your mannitol, before you touch the ventilator to increase the respiratory rate or the tidal volume or the minute ventilation, make sure the fidelity of the device of the intracranial monitoring is whether reliable or not. Secondly, you should ask the nurse who's telling you the ICP is high, is the ICP transiently high or is it persistently high? And if so, for how many minutes it's been elevated? It is normal physiologic consequence for anyone to cough or get agitated if someone is pinching them. They're turning red because they're waking up and they're agitated. All of these can increase physiologic and transiently elevated ICP. So you need to rule out these confounding factors and the things that are not true elevation in ICP. And lastly, and it's important, it's the focus of this subsegment of my talk. The moment you know ICP is reliably and trustably high and you believe it, the second question is not, where is my mannitol? That is not your second question. The second question is, what is the CPP? That should be your immediate second question. Once you know the number is correct, what is the map, which is the CPP, assuming ICP is not moving around? And here's why. There are two scenarios. Scenario A is when CPP is optimized, meaning let's say MAP is 100, your nurse just told you that ICP is 35, then 100 minus 35 is 65, and that's your CPP. Guess what? You can relax. You have time to think about what's going on. Is the hematoma expanding? Should I get CAT scan? Should I call Dr. A, Dr. B? Guess what? You have time to do that. On the other hand, when somebody tells you ICP is 35 and the MAP is only 60, which is usually considered a normal MAP. If you go to medical intensive care unit or any surgical non-neurological intensive care unit, MAP above 60 is fine. It's fine. It's usually fine. But not when your ICP is 35, because 60 minus 35 is 25. Now the cerebral perfusion pressure of 25 is basically an egg being fried. Your brain is the egg and it's being fried. It's melting. You should not relax. You don't have time. You need to do something immediately, because every second that person is having a melting brain. It's an absolute emergency. No time to relax. So I think for same 35 of ICP, one, you can relax. On the other case, you cannot. So you must determine which case, which scenario you belong to. How many of you think the following sentence makes any sense, or it sounds weird or strange? I start norepinephrine, Levophed, 0.5 mg per kg per minute, and titrate it up, IV drip, continuous infusion to treat ICP of 35. Meaning, if the ICP is high, I'm going to start pressor. That's not something that you hear normally. What you hear normally is, I'm going to start pressor because blood pressure is low, septic shock, right? Well, guess what? If you start pressor when ICP is high in certain patients, not everybody, you know, routine use of anything is thing of a past. The modern medicine and the future of medicine is never going to be a routine use of anything. It must be individualized. So I'm not saying start pressor for everybody, but start pressor when ICP is high in certain patients. Let me show you an article from early 1970s. So in this graph, if you look at maybe an old study, but there are still a lot of things we can learn from the past. If you look at the y-axis, is a regional cerebral blood flow. They use a xenon scan in order to quantify the milliliter of blood per 100 gram per minute, the y-axis, and the x-axis is perfusion pressure. You can think of that as the mean arterial pressure. So the top graph, this one, the one that goes really, really high, and that is, guess what? When the partial pressure of carbon dioxide, PCO2, is really, really high. It's maximally dilated. There's nothing that it's not really squeezing itself at all. It's maximally dilated, and the proportion, the relation is direct. All this pressure leads to really exponential growth of the flow, because things are really wide open, and if you increase the pressure, it's going to all turn into volume, which turns into flow. And as you go from top to bottom, you can see a really significant reduction in response. And much of those, after a certain point in time, it reaches a plateau. And the y-axis really coming down here, the levels really at the bottom when you have low CO2, meaning when you blow off so much CO2, they have shown this 50 years ago, that the vasoconstriction takes over and the flow response is not going to be robust to the blood pressure. Something to think about. And from there, we now understand the cerebral autoregulation, CBF curve, the y-axis, meaning the x-axis, when you increase the blood pressure flow will go up. And then there is a flat plateau zone where no matter what you do with your blood pressure, the CBF is constant, and brain likes that. Brain does not like yo-yo or roller coasting up and down flow. It wants nice, decent flow all the time. And that is by the autoregulatory, meaning the vessels are constricting and dilating and constricting and dilating depending on what the pressure and the volume it receives in order to maintain a constant CBF. So back to the starting the vasopressor to high ICP. So if you apply the cerebral autoregulation principle, if you increase the MAP or cerebral perfusion pressure, you jack up the blood pressure, guess what? You're going to have lots of flow. And a lot of flow means a lot of volume. A lot of blood is going to the head. Then ICP will go up. makes sense if vessels don't do anything. And that's why, and that is when you have this flat dotted line that you do whatever you do with the x-axis, y-axis value just directly proportional. On the other hand, if the patient's brain vessels are working, you raise the blood pressure, what would happen to the ICP? Well, you raise the blood pressure, perfusion pressure goes up, and then perfusion pressure drives the volume, so the brain detects more blood volume. Automatically, the brain vessel says, oh my gosh, this is too much volume. I'm going to vasoconstrict myself. So then when and if it does that, and that's the intact autoregulation, that the vessels are squeezing itself, then ICP will actually go down because now you're reducing the amount of blood volume. Reduction in blood volume means reduction in ICP because pressure and volume are the best friend. Pressure goes down, volume goes down. Pressure goes up, volume goes up. For the next few minutes, just a couple of minutes of my talk, I want to talk about, switch the gear and talk about the latest hot topic of the intracerebral hemorrhage, that is the surgical intervention. As you know, this dates back to many, many years ago. Stage 1 was the early surgery versus conservative medical management of the ICH, and it showed no difference. Then stage 2 showed, well, if you only pick those who had a superficial, so you don't have to dig in too much, because in the beginning, we opened up the skull, we went inside too deep, we caused retraction injury, we cut vessels, and that created more damage. Why don't we just do things that are superficial? Well, not much difference. MISTI 1, MISTI 2, MISTI 3. Well, instead of cutting open the skull, why don't we just put an EBD, a little catheter, drill a hole and put the catheter in the longitudinal dimension of the ICH, and you score a little bit of TPA and let some of the make the hematoma a little bit loose and suction out or let it come out. Well, it was a negative. And people took wrong message from it. A lot of people take wrong take-home messages from randomized controlled trials. Because it was negative, they say, I told you, nothing works. No intervention, things don't work. Well, guess what? Thrombectomy didn't work for 35 years for ischemic stroke either. But look what happened. Just because it doesn't show you what you want to see doesn't mean it doesn't work. The principle is the right principle. It doesn't belong there. Hematoma with a mass effect does not belong in anyone's head. It needs to come out. The question is how to do it safely. And from MISTI 3, in my mind, the take home was the following. And I encourage you to read it one more time when you have a spare time. Yes, the primary long-term outcome, it did not improve. But guess what? Those who had the catheter and a lot of blood came out, they got better. Unfortunately, most people who got EVD catheter in the hematoma, not much came out. So what good is it if you put in, but nothing happened? Of course, the long-term outcome is going to be no different. You put it in for one reason. You put it in to get it out. They didn't get it out. That's why it was negative. When and if, and I don't believe it's going to take a long time. In the near future, I am 100% confident that we will be able to get it out. And when we do, it's going to be different. The outcome will be much better. I guarantee you. I can't show it to you because it's going to take MISTI 4, MISTI 5, and MISTI 6. But it will come. In the meantime, instead of leaving the catheter in there and let the gravity just drain it and just pray that it'll come out, Instead of a passive evacuation, some colleagues have placed an endoscope. So this is a somewhat little more aggressive, but still minimally invasive because the diameter of these scopes are very small. Make a hole, put in, stereotactically guide where, so you know where you're going. And when you hit the hematoma, you visualize the center of the hematoma and evacuate. Actively suction it out. Evacuate. And when you evacuate using an active suction, obviously concern is one thing and one thing only. You know what that is? You may cause active rebleed because the tamponade effect of the hematoma is now relieved. You're messing around with the mass effect, and wherever it ruptured, it may bleed again. Some of the vessel may pop, and while you're drilling in, you might have violated some small veins here and there. Well, guess what? Then they can cauterize. You look at it with a camera. Oh, here's a bleeding. You zap, cauterize. So this is what people are doing. And here's a study from another country, and more studies from US showing that if you do a endoscopic evacuation, you identify the center of the hematoma, you identify the bleeding site, cauterize, and evacuate most of it. And they have shown this is not a randomized trial. It was only 100 patients, and they had a pretty big bleed. 50 cc is a large bleed. And 86%, unlike MISTI-3, which was really low number, they achieved a high percentages of successful evacuation defined by residual hematoma in the brain being less than 15 milliliter. And almost half of them had an excellent outcome. So this is obviously I think a light at the end of the tunnel. You know, just like we're hoping that COVID will be over soon, and I think it will be, it's a light at the end of the tunnel. We need more studies to confirm the finding or confirm our idea that the principle of mass effect of somebody's brain doesn't belong there, and it needs to come out, but it needs to come out effectively. You can't put a catheter in there, hope that it's going to drain and nothing happen, and show that it's negative. It's expected to be negative if they are all in there. You need to get it out and get it out safely. And I thank you for your attention.